the top 1% of most cited scientists. He's currently Associate Professor of Medicine at Laval University, Director of the Catheterization and Interventional Lab at Laval University, and Director of Research and Innovation at the Hospital Clinic of Barcelona. He holds the Research Chair Foundation Famille Jacquet-Larivière for the development of structural heart disease interventions. Thank you, Dr. Reyes-Cabal, for being here, and welcome.
It's a real pleasure to be here among all these friends and great team. And I will now, do you see well the screen? Huh? And I will share with you in the next minutes some thoughts about this emerging technology of transcatheter mitral and tricuspid valve replacement. We are still, when I see Greg and all the great job with the mitral clip, I think that we are really far from that. But step by step, moving forward, and I think that, as you will see, this could be really very nice complementary technology to the transcatheter repair techniques. These are my disclosures. This is a primary severe MR case that we treated last week with the newer generation mitral clip. We put two clips, XTW and TW, as you see, with a very good result. I wanted to start my talk with a case like that, which are very usual nowadays, to say that this is a very well established technology that works for many patients, like this one, which is not extremely difficult, but not the easiest one, with more jet, as you see here, more generating in 3P3. And as with all the work of Greg and other investigators in the COAP trial, we know that now that this technology is superior to medical treatment for treating patients with functional MR, meaning that this is, again, a well-established therapy, quite a safe technique, with a relatively low rate of complications and mortality, even in the initial series, as this one in the STS TVT registry. However, as you can see, in this case, a bit more than 10% of the patients ended with moderate or severe MR, and some of them, a few, had also a significant increase in the gradients at the end of the procedure, meaning that in this particular series, close to 20% of the patients ended with what we could consider some kind of a suboptimal result. And then from time to time, we have also seen cases where you end with a relatively good result. You increase the pressure during the procedure in order to ensure that this will be the real result in real wall conditions. But then you see the patient a few weeks later, and you see a significant increase in mitral regurgitation. It's not very frequent, but this happens from time to time. And you are all aware that mitral clip was inferior to surgery in the VEREST-2 trial. This was at the beginning of the technique. There will be trials. I know that there is an NIH designed trial that probably will start within the next months, comparing again the clip versus surgery. But the reality now is that for degenerative MR, seems to be an inferior therapy compared to surgery. No doubt, as I said, the newer generation mitral clip has improved our results, and especially has allowed us to treat more complex patients. We have a longer arms of the clip, a wider arms, and there is no doubt that we are obtaining better results, and especially treating more complex patients. However, when you see the results of EXPAND using newer generation mitral clip devices, you see that there is still a bit more than 10% of the patients ending with 2+ MR or more. And when you look especially at the decrease in MR, you see that about 30% of the patients failed to decrease the degree of MR of more than 2 degrees. They were limited to 0 or 1 degree, meaning that there is probably room for improvement in terms of the percutaneous treatment of mitral insufficiency. And then you have cases that even with the newer generation mitral clip devices are suboptimal cases for mitral clip, either because you have calcification in the grasping zone, either because you have a small annular area, or because you have a short or very short posterior leaflet. This therefore provides the rationale for the need of additional technologies. I'm not going to talk about annuloplasty devices today. I want to focus only in this emerging technology, which is transcatheter mitral valve replacement. This has been a challenging field, more challenging than the aortic space, because the mitral anatomy is more complex. We have an asymmetrical annulus with a complex valvular structure, no calcium, which is an important part for the fixation of the valves in the aortic annulus, and there is the potential interaction also with the LVOT. Despite of all these challenges, up to 9 valve systems are currently being evaluated in humans. Many others are being in the preclinical evaluation, and others have already been evaluated either preclinical or in human and failed. Again, this is a very complex field, meaning that there has been a lot of progress. One of the problems that we have in TMVR compared to TAVR is that there are some valves that are based, the fixation mechanism is based on radial force. You oversize the valve, and this is the main mechanism for valve fixation. But there are other mechanisms, including apical catheter, annular winglets, native leaflet engagement, mitral annulus clamping, etc. This provides you an idea of these challenges regarding valve fixation and stability in this complex anatomy. Unlike also the transcatheter H2H therapies, pre-procedural CT is mandatory for preparing the case, as it happens also in the TAVR field. We need 3D CT to have accurate measurements of the annular dimensions. We need to establish the point for transeptal puncture, but more importantly, we need to evaluate the risk, the potential risk of LVOT obstruction in these cases. And the idea is there have been softwares that have been developed where you have a virtual implantation of a transcatheter valve, and this allows you to calculate the residual area at the level of the LVOT. And if this estimation is below 1.7 centimeters square, you consider that this patient is at high risk of LVOT obstruction. And in fact, many of these patients have been excluded from trials like the Intrepid pilot study, where these reason, the risk of LVOT obstruction, accounted for more than 25% of the patients. The other two main reasons were either that the annulus was too small or too large for the valve sizes that were used in the trial. However, it's very interesting that all these concepts on parameters predicting LVOT obstruction have been developed with non-dedicated devices, with transcatheter aortic valves that were implanted off level, the level of the mitral annuli in desperate cases, mainly MAC cases. And this is a study that was performed with the Intrepid patients. And as you see, when you measure the neo-LVOT at end systole or early systole, it makes a huge difference. And the investigators of this study found really that the measurements as recommended at mid to end systole did not correlate with a clinically relevant LVOT obstruction. It was more the early systole measurements that correlated with this risk of LVOT obstruction. This is a very important aspect because probably many of the patients that were refused to be included in this trial could have been included with no particular risk, meaning that this is an aspect that I'm sure that there will be a lot of studies and research in this field, because it's very important, and again, is one of the main challenges of TMVR. As you will see, the rates of LVOT obstruction in the trials are extremely low. And the reason is everyone has been extremely conservative and not allowing to enter patients with an increased risk of LVOT obstruction based on quite conservative parameters. As you can imagine, the mitral valve is a very large valve that is positioned in a difficult place, meaning that if you want to go transfemorally, it's relatively challenging because you need really big catheters with a lot of different maneuvers, anterior, posterior, lateral, medial, in order to center your valve. There is no doubt that the transapical approach is straightforward. You can easily put the valve in a good position, well-centered, with no much problems, and you can use relatively large catheters. Usually, the transapical systems that have been used are over 30 French, all of them. And this is the reason why this technology started transapically and has evolved in many studies transapically. There are mainly three main valve systems that have been used. This was one of the first, if not the first, valve implanted in a dedicated system in the mitral position, the Tiara valve from a Canadian company. And as you see, these are the results of the early feasibility with this valve. Again, you see really good results in terms of valve performance. However, at the price of a relatively high death rate at 30-day follow-up, mainly related to the thoracotomy, transapical approach, problems with hemostasis, major bleeding issues. We have the Intrepid valve, as you know, and I know that Dr. Adams is very involved as a PI in the pivotal trial now. This is a valve that has an outer stain frame between 43 and 50 millimeters, and then an inner frame with including a 27 millimeter 3-leaflet bovine valve. And this valve the fixation of this valve is based in radial force with an oversizing of 10 to 30%, but also there are clets that increase the friction between the valve and the mitral leaflets and ensure the accurate fixation of the valve. These are the results of the pilot study. Again, extremely good results in terms of valve performance. I didn't put the mean gradients, but I can tell you in general, the mean gradients with all valve types have been below 5 millimeters of mercury. The mean is usually 2, maximum 3 millimeters of mercury, meaning that we don't have, I'm not aware of cases of stenotic problems when you implant these type of valves. However, again, due to the transapical approach, mainly high rate of major bleeding complications, probably explaining this death rate over 10% at 30-day follow-up. And finally, the Tendyne valve for Abbott, as you see, the valve is fixed with a tether in the apex of the left ventricle. Again, the rate a bit lower, but again, significant incidence of major bleeding issues. There are now 2 important trials ongoing, 2 pivotal trials, one with the Tendyne valve, comparing the Tendyne valve versus MitraClip. There are also registries in MAC and non-MAC patients, in patients suboptimal for MitraClip. And then the Apollo trial comparing the Intrepid valve versus surgery. And I saw recently an amendment including allowing also not only surgical patients, but also MitraClip patients in the control arm. There is also a registry with MAC and non-MAC patients not eligible for mitral clip. These are very important, and I think that Apollo trial for me was very courageous to, with the results of the pilot trial, to move forward with a trial against surgery, but probably was the good decision in order to have a final response of whether or not this technology really works and can be approved for general use. I think that in the next few years, the results of these trials will be very important for these technologies. There is, however, no doubt that as it happened in the TAVR field, we should move towards less invasive therapies, not requiring thoracotomy. And the idea would be to have more and more transfemoral TMVR systems. Here we are really in the very early stages. As you see, we have already pivotal trials with transapical systems. This is not at all the case with transfemoral systems, but I would like to share with you some of the experience that we have had with transfemoral systems, which is, I could say, encouraging. There is a lot of still of work to do, but as you will see, this is somewhat promising results. This is the M3 valve from Edwards. It's a very elegant concept where you have a dog that is placed at the level, is an ethanol dog placed at the level of the subvalvular apparatus. This provides the landing zone to implant a 29 Sapien 3 valve with some iterations, as you can see, but in fact is a Sapien 3 29 millimeter valve that is implanted using this landing zone as a mechanism for fixation. The advantage of this is that we know the valve, and you can use a 20 French sheath catheter, which is really small for TMVR technology. These are the results from the early feasibility. The initial cases was performed in Vancouver by the John Webb's team. But in the early feasibility, you see really that the valve performance results were quite good, with about 6% of patients with mild, moderate, or moderate severe MR. And the mortality results were seemed to be better compared to the transapical access. There were, however, a relatively high rate of stroke and some cases of valve thrombosis. But for the initial results, I think that are quite acceptable. Now we are moving forward with an expanded feasibility study. We had the opportunity to work with the other system from Edwards, which is very different, which is the Evoke system. As you see, this is a system where the fixation of the valve is based on a series of ventricular anchors that capture the anterior and posterior mitral leaflets and anchor and stabilize the valve. The system is a 28 French system that is used transfemorally, and the valve, the current diameters go from 44 to 48 millimeters. There is the idea of having also a 52 millimeter valve. You see here, this is the initial expansion, and this is the most important part of the procedure, where you have to ensure that your anchors really capture the mitral leaflets, as you do with the mitral clip, because otherwise the procedure will fail. It's the important part. When you ensure that you are capturing really the leaflets, then you pull back a bit the system, and then you finally release. And as you can see, there is no retention at the atrial part. All is based on these ventricular anchors. These are the final results. This was the first patient that we treated in our institution with a very good result. And these are the preliminary results. Very small number of patients, only 14 in well-selected centers. And as you see, the results were very good again in terms of valve performance, with really no cases of more than mild MR. However, again, 7% of death, some strokes. We are not sure why exactly these stroke rates are there, but definitely the stroke rate seems to be higher than the stroke rate observed in mitral clip patients. After I will show you on a slide where we compare a bit the results of TMVR with those obtained in the COAPT trial to see really the differences between the two technologies. We had also the opportunity to evaluate the Cephea system, which is the TMVR, transfemoral TMVR system from Abbott. And this is a very, I would say, a straightforward valve system because it's mainly based on radial force and is more or less like implanting like a TAVR valve in mitral position. As you see, this is the valve with is a nitinol valve, which comes now only with a diameter of 36 millimeters. There are more valve sizes that are being iterated. But initially we look, and you see this is the first case that we treated in our center. You see the patient had a significant MAC, and despite of that, we decided to move forward. The valve for sure opens at the mid portion of the left ventricle, and then you pull back the system. And when you see a contact of the system with the annular roof, then you open the atrial part and you liberate the valve. Here is the system. We treated up to 3 patients in our institution more than 1 year ago. All of them are doing well. And unfortunately, the pandemic stopped many things. This was one of the things. We were not able to do more cases, but now there have been iterations, very interesting iterations in the delivery system, particularly on valve sizes, and we will be able to start treating patients soon. And we are also designing an early feasibility study in the US and Canada with this valve system. Again, I think this will be also a very competitive valve in this field. These are the final results of our first patient. Again, as I said, there were 2 additional patients that we treated with good results. For sure, I selected patients mainly because we were limited by the only valve size that was available. And finally, I will end with a very different concept, which is a completely supraannular valve. This is the altaval system, and as you can see, it's a nitinol cage that goes up to 90 millimeters that accommodates to the size of the left atrium. And the valve is inserted, in this case, is a 27 millimeter valve that is just here and works completely supravalvular. You see, you are not really interacting with the subvalvular apparatus. You see, this is the mitral regurg of the patient that is still there, but then you have the valve of the new valve system that is completely supravalvular. And you avoid all the problems with the LVOT obstructions or valvular apparatus, etc. Meaning that conceptually, it's interesting. We see this also interesting maybe for mitral clip failure patients where TMVR can be a challenge, even if there have been some Tendyne cases that have been done. There are techniques to electrocauterization of the anterior leaflet, but still it's a challenge when you have a clip in place. And this device can potentially overcome these challenges. There have been up to 6 cases treated transfemorally. Up to now, there are not still the results have not been reported yet, but the transfemoral system is there and has started to be used. And there are, as I said, other valves, including the Intrepid valve. There have been some cases I know that have been performed in humans with the transfemoral system. We don't have the results yet, but there is no doubt that all valve systems will try to evolve towards a transfemoral system because it's much less invasive. This is a slide that summarizes a bit where we are with the TMVR technology versus the well-established mitral clip technology. These are the COAPT patients. As you can see, this is the initial cohort of TMVR patients, a bit more than 300 patients, similar STS compared to COAPT, and the majority of patients were also functional MR as COAPT patients, meaning that it's a comparison that is probably not completely fair, but still, I think that provides an idea. This is the problem with TMVR. There is a huge gap in terms of 30-day mortality. Again, it's early experience, COAPT included experience centers with MitraClip, etc. But we have to recognize that particularly, I would say, with MitraClip system, but also with some transfemoral systems, we have more safety issues than the MitraClip, a higher rate of a stroke, as I commented before. However, when you look at valve performance, these technologies seems to be really superior to MitraClip, with nearly no cases of moderate or severe MR, meaning that this is something to take into account. Remember the cases that I commented before, cases that are suboptimal for the MitraClip therapy that could be eligible for these type of technologies. Again, is a work in progress. This is how I see a bit the summary of what we were saying. I think that there is no doubt in terms of safety and screen failure, MitraClip is much better. However, I think that in terms of valve performance is a technology that can be very competitive. How I see the field for the future? There is no doubt that we have to reduce the screen failure rates. It have been systematically over 50%. This is too much. Many patients that are screened are refused. Again, the problem of an overestimation probably of the risk of LVOT obstruction was important, but we need more valve sizes. It's very important. We were restricted to only a few valve sizes, and we realized that we need really larger valves, there is no doubt, but also smaller valves. We need really to tackle the risk of LVOT obstruction. I think that there have been some work, but the Intrepid sub-study was important to say, look, maybe we have been overestimating really this risk. We need more repositional retrievable valve systems. And for example, I know that one of the iterations that is being done with the Evoke system is to build a fully retrievable valve. This will be very important because then you can implant the valve. If you see really that there is an important LVOT obstruction, you remove the valve and you abort the procedure. This will increase a lot the safety of all these procedures. And then we have no idea of valve durability. Which we know from the surgical field, valve durability can be impaired in the mitral field. We have this was the first valve that we used in our center, was the Fortis valve from Edwards, implanted transepically. We did some cases, and a 2-year follow-up is quite promising in terms of no late thrombosis, no late valve dysfunction. Similar results at 2-year follow-up with the time-bound valve with no structural, but we are talking about 2 years. We need really much more. The advantage compared to MitraClip is that probably if the valve fails, probably you can do a valve-in-valve procedure, but this is something that we will need to prove in the future. Tricuspid regurgitation, we are even in more early stages of all these technologies. These are 2 examples of the most frequent causes. One of them is a patient with a prior left valve surgery, and another one is a patient with chronic AFib, which are patients that we are seeing more and more developing very severe tricuspid regurgitation with no other reason. We know that tricuspid regurgitation is associated with poorer outcomes, irrespective of the cause. And we were talking recently with Michael Mack and David Adams about that. There is no doubt that the surgical results can be very good in good hands and good patient selection, but the reality overall is that the mortality rates for isolated tricuspid valve replacement or repair have remained quite high, around close to 10% over time, with not much improvement. Probably, again, patient selection has been a major aspect. Patients are probably referred to surgery too late in a too advanced stage of the disease. There is, however, I think that the community recognizes very well the real need for transcatheter, less invasive therapies for this population. I think that the need is even more important than in the mitral space maybe, because again, all these maybe less optimal surgical results The problem is that we are facing here a valve that is even more challenging in terms of anatomy compared to the mitral valve. It's a very large valve, non-calcified, tight angle between the superior and inferior vena cava. We have the proximity of the AV node, right coronary artery, and then we have many, many patients with pacemaker or defibrillators leads in this space. Despite of that, many repair therapies have been developed in the last years, and the most important, popular, and most frequently used, initially of level, now already approved, has been the MitraClip, now the TriClip device in the tricuspid position. These are the, I would say, I'm presenting like what I could consider a prototypical case. This was a case treated with a coaptation device called Forma, but is no more used in clinical use, but it provides an idea of the results, usually associated with quite good improvements in functional status, but this again is the result that you observe. We have torrential TR and you end with moderate TR. And this is, I would say, a very frequent outcome. It's very rare that you end these procedures. We see more and more in the mitral space with the new generation MitraClip, very, very good results with trace MR, mild MR, but it's very rare, more and more, especially when you select well the cases. Here is very common. More about 1/3 of the patients or more will end with moderate or severe TR. However, as I said before, many of these patients started with massive torrential TR. But there is no doubt that probably this will impact the outcomes of some of these patients. Not maybe at short-term follow-up or early outcomes, 1-2 years, but if we are talking about 5 years, 10 years, there is no doubt that ending with moderate or severe TR will impact the outcomes. And in fact, when you look at the data from the Trival registry, ending with a suboptimal result, moderate to severe TR, is associated with poorer outcomes, meaning that there is really a need to improve the results. There is no doubt that repair techniques will also improve. We will see better and better results. But again, this is a space that it will be, I think, in my opinion, a bit more difficult to have the type of results that we are achieving with MitraClip in the mitral space. This is why transcatheter tricuspid valve replacement, we think that may play an important role in this space. And this was the first case that we treated with the very first valve that was manufactured for the tricuspid space. The very first case was performed in the Cleveland Clinic more than 3 years ago. We did this case about 2 years ago, and the patient is still doing quite well. And you see the result was really very good. This is a valve, however, that needs to be implanted at least nowadays with a 42 French catheter. You imagine the size of the catheter, and this requires for most of the patients right thoracotomy, which is already a challenging aspect. It's feasible, there is no doubt, but again, we talk about the problems of thoracotomy. These are frail patients, high-risk patients, etc. The valve, however, comes from sizes from 36 up to 54, which is very interesting. We need really sometimes very big valves in this space. And these are the results of the initial gate experience. And you see that there are problems. There is no doubt. The mortality rate was 10%. And unlike the TMVR systems, where even in the initial experience, the result was nearly perfect in terms of residual MR, here you see a significant proportion of patients, about 25%, ending with moderate or severe TR. Again, we had a lot of massive, we had a lot of torrential, but still you would expect a bit better results. And I think that this means that we have to work a lot, and highlights the fact that this is a much more challenging space. Similar results were obtained also with the Lux valve. This is a valve that made in China. And these are the results of close to 50 patients. And again, procedural success very high. Is again a procedure that has to be performed through a right thoracotomy. There are systems that are being developed transfemorally, but we are still the systems that most of the systems available are still, we need a right thoracotomy, and probably this is one of the reasons why the mortality was relatively high. But again, residual TR more or equal than moderate, it's probably higher than you would expect for a valve replacement system. This is only a very rapid example. The Tricuspid valve is a valve from Israel, and in fact, the first case was performed about 1 week ago successfully in Israel. We were supposed to do a second case here this week, but due to the pandemic, it was impossible. But we will be able probably soon to try this valve system that has a particularity. You see, it's a bi-leaflet system. It's one of the only bi-leaflet systems that I've seen, and in such a large valve and such large annuli, maybe it makes sense. And interestingly, the system is implanted through the jugular. And the EVOQUE valve is the same EVOQUE valve that we saw for the mitral space, has been implanted transfemorally in a patient with tricuspid regurgitation. There have been around 30 patients treated in different centers now. The results are not have not yet been provided, but we are moving forward because with this transfemoral system, there is an ongoing study with 200 patients, kind of a feasibility safety study. And then there is a pivotal trial that has been designed comparing this valve with optimal medical treatment with this primary composite endpoint. I think it's very encouraging because I think, again, in this field, if a valve works, it will be probably even more important than in the mitral space. I will end then this talk with some bullet points. I think what we can say about transcatheter mitral and tricuspid replacement is that this is a technique that is feasible, and we have good valve performance results, particularly in TMVR, room for improvement in the tricuspid space. We have, however, a relatively high rate of periprocedural complications, mortality, partially due to the transepical approach, but also due to the systems that we are using and some other issues that we will have to solve in the future in order to make this type of technology competitive. We need further valve system iterations. If I have to pick up two, I would say fully repositionable, retrievable valve systems. This will increase a lot the safety of the procedures, and more valve sizes. We need really to, if we want to treat a broader number of patients, we need more valve sizes. And finally, as I said before, I see these type of technologies as a complementary to transcatheter valve repair systems. I guess that in 3 to 5 years from now, we will have a significant proportion of patients treated with the good transcatheter repair systems that we have, others that will be developed, and these will we will be able to treat probably 2/3, 70% of the patients, and then the TMVR or transcatheter tricuspid replacement will be a complementary technique. Thank you very much for your attention.
Thank you very much. Can you hear me?
Yes, very well.
Can I ask you a question, Marty Goldman? What we've seen is that the mitral regurgitation, you fix the mitral valve, but you don't fix the ventricle. So the key thing is what happens to the ventricle. And you know, we know that the discussion between the French trial and the COAP trial is that proportionate, disproportionate mitral regurgitation. Do you assess that now with that paradigm that the mitral regurgitation is the cause of the ventricular dysfunction or just the result of the ventricular function dysfunction? So do you monitor that before you consider doing the mitral clip? And I guess a corollary question, how many times just by improving, maximal medical therapy, do you resolve the severity of the regurgitation so it doesn't require an intervention?
This is, Dr. Roman, a very important point. All the cases that we treat are discussed in a weekly meeting with heart failure specialists, echocardiographers, and cardiac surgeons. It's an expanded heart team, and I would say there is no patient with low ejection. I'm talking about functional MR that is being treated without an optimal medical therapy. These include resynchronization and all the new therapies that are available. We are quite, I would say, strict. One of the things that we have learned also is that I would say that no patients nowadays. We are trying to avoid to treat patients with, for example, TMVR is much more aggressive than the mitral clip. Even the result, I would say, because with this complete abolition of MR, you usually have a reduction in ejection fraction, at least temporary. And sometimes these patients don't tolerate very much this type of sudden hemodynamic changes, meaning that we are trying really to select patients based on the COAP trial criteria. And I would say that this is part nowadays of our routine, really trying to identify this type of COAP-like patients. This, I think, was an important trial, especially compared with mitostans.
Yeah, I enjoyed your talk tremendously. It was great. So I have two questions for you. Number one, on the mitral side, the results of COAP were better than most people, including us, actually even anticipated. So do you think that transcatheter mitral valve replacement, because of its ability to eliminate MR in most patients, will actually improve on those results? Or do you see transcatheter mitral valve replacement more being reserved for patients who are not eligible for the mitral?
At this time, I see more reserved for those patients not eligible. I don't think really that we are, as I said, that we are in a position really to be superior to the in general to mitral clip, because I'm not sure that the safety issues and the increased complexity of the procedures is something that you pay a price for that. I'm not sure that then this further reduction of MR can really compensate. This being said, I think really in the future that the cases will be evaluated, and you have perfect cases for mitral clip, and we know which cases are. And these cases can be very well treated with clip or other repair techniques. However, the cases where you say, I'm not sure, etc., I think that this is where TMVR can play a role.
Right. And what's your thinking right now about needing to anticoagulate with different valves, mitral and tricuspid?
It is an unsolved issue. Fortunately, unlike transcatheter aortic valves, most of these patients receive already anticoagulation. Many of them will switch from DOACs to Coumadin, to warfarin, because we don't know exactly the role of direct anticoagulation therapies. But I think that nowadays anticoagulation is mandatory, at least for the initial months for all these patients. There have been some problems of valve thrombosis in the mitral space, and I think that this was partially related to the underuse or suboptimal use of anticoagulation.
Great. I'll ask you one last question. For 20 years, we've heard from the surgeons that, repair, right? And now we are focusing on transcatheter field on a lot of replacement technologies. To me, it makes really good sense on the tricuspid side. I think there's often so much torrential tricuspid regurgitation. I think it's going to be very hard for repair technologies to approach that. The real downside, though, of clip technology is the fact that you're permanently altering the anterior and posterior mitral leaflets. And so you actually are almost, if there ever needs to be anything else done, now you almost need surgical repair. So do you know, are there, one, how does that affect your thinking when you're deciding to do a leaflet approximation therapy? And two, do you know of technologies that are being developed to remove a clip if necessary?
No, it's a very good, the only technology, I know that there are technologies that are being developed. The one that I saw is really the use of electro cauterization techniques for the anterior leaflet in order to be able to implant a valve. I think that I would say, Greg, that I was surprised to see that Everest at 5 years, now COAP, I think that the results are quite stable. When you talk to the surgeons, many of them, they say, look, you clip, you do the Alfieri technique, 5 years later, you will have again a lot of MR. It doesn't seem the case.
No.
Up to now, and I think that everything will be, this will be the key part of all this aspect, whether or not the results of the clip are maintained up to 10 years or not, because we don't know, we don't have any clues about valve durability yet. But I think that this will be a major debate when we will start treating lower risk patients. With longer life expectancies. I will have to leave.
Oh, yes, okay.